Thanks, Michael, for that insightful 10 minutes whirlwind review of what or reply of what Esther had presented. I actually like your very last sentence that says, "Thank you, Esther, for taking on the work and you have volunteered to push this forward." I also echo that. Now, I've just looked at the chats, and there are two questions that would fall nicely into the second sort of question that comes about. We do have about 20 minutes to sort of go through some of the questions. The funny or the unique thing about Hume is that we tend to get questions even before the speakers have expounded on their topic. So we would usually get 9 or 10 questions that demonstrate to a certain extent that the participants or those that have signed up actually are engaged. So one of the themes that have come across is this recurring question from the audience that reflects really the discomfort of uncertainty. I guess a lot of what we have mentioned, right, is the akan datang, meaning to be developed, to be done, but then yet we had to do this and that. I guess it's really awesome in that it's inspiring there, but yet you are frightened that you may have to do all this. Clinicians often want to know, or healthcare workers want to know whether they have capacity or not. But now you are suggesting that there are a group that actually we would never really know. So how do we become comfortable making good clinical decisions without certainty if certainty is really not attainable? And when does this pursuit for certainty become really ethically counterproductive? Any thoughts at all on this?
I think that especially for geriatricians, right, we do see a lot of this type of patients who are very gray, and we're not ready to, for example, make a decision about whether patient has or has not capacity. And how I look at it is that we get a very sort of narrow glimpse into the patient's life at the point of our clinical encounter, whether it's in the clinic or in an admission, and it's difficult for us to make a clinical judgment at that one point. A lot of times we need to take a step back, and instead of looking at snapshots of the patient's life, it's really to look at the patient almost like watching a movie, right? Look at the general trajectory, look at all the supporting factors and information that we gather along the way, and really just sort of like, monitor the patient over time. And as we get more and more of the story that is filled into this sort of like longitudinal view of the patient, it allows us to also build rapport with the patient, find out a bit more, and be a bit more sort of confident in ultimately in some of the recommendations or decisions that we make for them. So, but this is truly something that will take a lot out of a healthcare system, right? Because that means that we need to continue to follow them up longitudinally. And in my own clinical practice, I have many patients, because I run a memory clinic, who are like that. And I end up following them for a long period of time because they're socially frail. No one can make a decision for them or help them. And so I'm holding them on and seeing how they develop over time. And then that eventually may be when it sort of shows itself a little bit clearer, that in good faith, I can say that, okay, I think this is the way we should guide the patient in making certain decisions. And I think sometimes if we are too quick to try to, because of time pressures, to make a decision like, patient is going to a nursing home, and then commonly this is what we always say, right? We get a request to say that, can you decide if patient has mental capacity for financial matters, right? But truth be told, we cannot assess, right? Because if there's no history, we don't know that we're not able to assess the patient at that point of time because they may be delirious. Then that is counterproductive. Yeah. So over back to you.
Yeah. Michael, anything at all that you want to add on to this element of how we actually deal with this level of uncertainty and when it becomes really counterproductive?
Yeah, I mean, I think uncertainty is almost built into the Mental Capacity Act, because we can't even say really that the person lacks capacity or has capacity. What they actually lack is the ability to make one decision, right? So we have these heuristics that we work with that allow us to basically practice in an appropriate way. And I think the law is flexible enough to enable that degree of sort of heuristic management of uncertainty. We can say, look, by and large, we can work with people as if they need our help and as if they don't, depending on whether they have capacity or not. But strictly speaking, that's not lawful. You're supposed to be assessing capacity for every single decision that the person's making, right? So we have to live with that uncertainty. We have to marshal it. We have to manage it. I think supported decision-making helped with the uncertainty because I think it gives a renewed framework to manage something in a very clear, almost universalizable way for everybody. Regardless of whether you're on the margins or not, you can actually just apply this framework and improve the quality of ethical decision-making if you accept the idea that this is more respectful of their autonomy.
Thanks for that comment. I'll move on to maybe the next section in terms of this tension between how we balance autonomy versus protection. And some of the questions that have come in have rightly or wrongly criticized that the legal system tends to be too rigid, as what was discussed before, to really be fully applicable from the clinical context. So, for example, the issue of whether or not when we place the person under the Vulnerable Adult Act by GINA, and then it seems to be just perpetuating the situation, as well as the previous comment in terms of by Teck Joo that basically the legal definitions make decision-making capacity really quite challenging. I guess this was expounded on somewhat during the talk. So we also received some other questions that are asked about if the patient knows the risk and yet wants to do, or the family insists on doing things that are objectively bad decisions. How do we actually negotiate that? How do we distinguish between genuinely respecting a person's autonomy and simply abandoning it to them? I think this was discussed before, but I guess to put a finer point on it. In other words, where is the line between respecting choice, fulfilling our duties of care? Any sort of thoughts on how we find that balance? How would you do it, Esther, in such cases? How would you balance autonomy and that of let's say protection of the patient in let's say on the ground on a clinical basis?
Yeah, so actually, truth be told, I think we do see that quite a lot on the ground with a lot of our patients. And sometimes it's collective wisdom in a multidisciplinary approach, right? So like, MDR, we speak to our therapists, we speak to our nurses, our social workers, and collectively we make a nuanced decision about giving a trial, for example, of discharge home, and lay safety nets, right, to for the patient's care. So we may say that, okay, the least restrictive way may be to, patient may be like a bit gray, not like, fully independent, but yet not like really unsafe yet, but we'll let the patient go back. And then what we'll do is either we give a safety net of asking our colleagues in community health to check in on the patient's ability to cope. We refer to case managers, our social workers, they do home visits. We continue to give a SOCTCU to follow the patient longitudinally to sort of like catch them in case, they deteriorate, and so that we can intervene appropriately when the patient has sort of tipped over the fence whereby they are no longer able to safely be managed by themselves. Yeah.
It reminds me of this zone of discretion, the issue
Yes.
of whether or not it's just purely one best interest and that makes the target different, but you allow some level of suboptimal care, but not to the
Yes.
point of harm.
Yes.
And
yeah.
that judgment call of the clinician ends up being important in balancing this respect for the person,
Yes.
but not to the point of harm.
Yeah.
And I think a lot of the principles, whether it be the Mental Capacity Act, the Mental Health Care and Treatment Act, and even the Vulnerable Adult Act, would actually ascribe to some idea that there's a zone where medical care may not be optimal, but
Yeah.
we may need to allow it with safety nets
Yes. Yeah.
and allow for that trial.
Yeah.
Any
and
thought?
also,
Yeah.
Oh, and
Go
also,
ahead,
I
go
mean,
ahead.
just last piece, which is that a lot of times, right, we have our own viewpoint, the physician's viewpoint, whereby what we think is safe. But I think I want to caution people about like, making a decision based on what they think is the right thing to do. But really, take a step back, helicopter out and ask yourself, like, if I was in my patient's shoes, what would be a better thing to do, right? So we give them a little bit of that leeway. So that's why that would be less paternalistic, and then that will also allow us not to make decisions that ultimately may be too paternalistic for the patient. Yeah.
That is really lovely because it is from the hume's point of view, we want to have a pluralistic understanding of how we see things. And of course, that level of humility to say, I may not be right all the time. So that's a very powerful message. Michael, anything to comment on at all?
No, I think just in terms of this balance between protection and empowerment, it is the fundamental ethical challenge in all of this work. And it's a challenge for practitioners. It's also a challenge in the law and policy, right? So, it's very odd in a country to have two laws, the Vulnerable Adults Act and the Mental Capacity Act, essentially endorsing at their core different value commitments. The Vulnerable Adults Act is much, much more protection focused. The Mental Capacity Act is much more about giving people the rights to make decisions as far as they can. So we've got this tension built in at the very highest level of our legal framework, and we have to just work with that reality because there is no easy answer to how to balance those things. I would say that we should be a bit careful about going down the radical supported decision-making route. One of the other questions in the chat asked about international approaches and how they've taken shape. And there is a note here about Republic of Ireland worth making, where they have basically tried to introduce an entire supported decision-making law and got rid of substitute decision-making as much as they can. And it hasn't really worked, I think is a fair point to make. It's paralyzed healthcare practitioners because you have a national decision-making support service and supporters get appointed. And essentially, anybody who's not in that support relationship is denied any authority to decide. So if the supporter says, look, this is the person's will, this is their preference, yes, it's a bad decision, that no one can do anything about it, essentially. And only when the person is most severely disabled can you resort to substitute decision making. So, I think we have to recognise that we need a balance between the professional viewpoint and the supporter's viewpoint in whatever decisions are being made. But the idea of involving a supporter, advocating for the person, and the person participating is, I think, a nice balance as far as we can get.
The last big theme of questions, and I'm conscious of time, is that today's presentation has made supported decision-making sound less like a single intervention, but really like a more like a culture of practice. Yet so many in the audience are asking questions like, what's the role of the nurse? What's the role of the allied health? What training is available? Hume activities and courses to attend, and of course the supportive system. So if we truly believe supportive decision making is the way to go, what is one of the changes healthcare organizations need to make for this to be a practical sort of day-to-day activity rather than just this ethical ideal that we are discussing around the table? So any thoughts on this? How can we make it step by step? And Michael has volunteered Esther in how we're going to go ahead to do this. But just jokes aside, how do we think we can move this forward?
I think first of all is like what I shared earlier. As healthcare workers, we need to ask ourselves first and foremost whether we think this is the right thing to do for our patients, right? And if we subscribe to the ideal, then we will look at what we can do to help our patients. I think we need to ask ourselves, like, besides looking at certain outcomes, with regards to supported decision making, it may require us to, for example, keep the patient longer in our follow-up. May need a longer sort of assessment period or, clinic session, and may need more people to be involved in the patient's care. So that may be value for the patient in terms of care. But of course, the trade-off is, we may not be able to achieve other forms of outcomes that may be relevant, okay, for lack of a better way of saying it.
Michael, anything at all?
I think this is really hard, and I really like Esther's approach here, which is say, look, let's start with a group of people we know are the most difficult to assess and to work with and to make the right decision. So people at the margins, older people with mild, moderate dementia, those seems like a good place to start. I think there's a couple of things. One is the idea of a champion, right? So you need somebody who can drive the principles and the approach locally. I don't think this is a top-down way of bringing about change. You need to be able to model, I think, a local manifestation of this practice. And so having a champion, someone like Esther, not me, in doing that, I think would be really good. I think there's also an interesting question for supported decision making, which is the degree to which a professional like a nurse, social worker, could take on a support role when there's not a family member, or as a mediator between family potentially. So there does seem to me to be a question about whether the best person to be a supporter is always the family member or whether it's somebody else, particularly when a person has a long-term chronic illness and there's a long caregiving relationship that involves multiple professionals over time.
Thank you so much. I actually hosted another webinar this morning, and they were talking about prems and proms. So that may really be the measure in terms of not just how short and how fast and how quick you need to transit such patients to a general practice, but really if the complexity is that high, then the proms and the prems may be good measures for such high acuity patients. I'll just make some concluding remarks and then we'll make a close. I guess a lot of this beginning is in terms of a reorientation. This the ethical shift, and then we hope that the legal reform may follow. Many clinicians still think that supported decision is after when you say the capacity assessment. Maybe there should be a reorientation to say, let's maximize agency before we even talk about capacity. And that is, I guess, when I say clinicians, it can be the support of the nurse, the allied health. I know in the diabetic clinic, the podiatrist does a lot of talking to the patients, and they may be the ones who know the patients the best. And secondly, as Esther mentioned, and I will echo, capacity as a spectrum rather than a threshold. And we want to move away from asking, does this patient have capacity, towards what supports would enable this patient to participate meaningfully in today's sort of discussion. That subtle change is actually very powerful, and ironically, it will put you in good medical legal standing if you have that mindset as well. In the last 2 minutes, in closing, there's not much for me left to do, but to thank our panelists, both Esther and Michael, for your thoughtful and insightful sharing and reflections. Also, thank you for the audience who have engaged with us for the past an hour. I've monitored the numbers, and the numbers have just gone up and not dropped down. So I hope that our talk has been really engaging, such that people have stayed on. What I want to remind you, there's another MME eligible webinar by Hani, Dr. Neo Hani, and Ms. Kwa Bunting coming up in September. That's a really interesting one, and I hope that you all will sign up for that. The EDM will come out in due course. And finally, please give us feedback, how we can improve, and then sign up if you think there are useful activities. Thank you again for spending your time with us, and I hope to see you again at our next webinar. Thank you, Michael. Thank you, Esther. And thank you, team, for putting this up. Thank you so much.